So now we have Dr. Neha Khurana. She'll be speaking on rare case of accommodative loss after barrage laser, novel rehabilitation using topical pilocarpine.
So very good afternoon to dear colleagues and the judges. So today I am here to present before you my rare case of accommodative loss after barrage laser in myopic eyes and novel rehabilitation using the topical pilocarpine. So topical pilocarpine in presbyopia is a hot topic nowadays. So probably I thought this was a relevant topic. Accommodation, as we all know, is mediated by the short posterior ciliary nerves. Damage to these nerves is a rare complication after retinal photocoagulation. So we report a case of accommodative and pupillary paralysis after barrage laser, which was managed using dilute pilocarpine drops. So this 18-year-old female, she presented with flashes and floaters. She was a myope and had multiple lattices with atrophic holes in the fundus. Barrage laser with indirect ophthalmoscopy was done in both eyes uneventfully using a double frequency anti-AIOC laser. Till now, everything was fine. So the next week, 1 week later after the laser, she presented with inability to read, headache, glare, near vision reduced to N18, pupils were dilated, pupillary reflexes were diminished and symmetrical. Unremarkable well lasered fundus was there. There was no fluid in the macula or anything. Distance aided best corrected visual acuity was stable at 6/6. So now we diagnosed her with bilateral internal ophthalmoplegia because he had accommodative as well as pupillary paralysis, probably secondary to the SPCN damage. So how did we confirm this? We confirmed this with a dilute pilocarpine test. We administered 0.1% pilocarpine in both the eyes, and we saw that the pupils which were totally dilated, they constricted to pinpoint pupils. So what had actually happened was denervation hypersensitivity. As in this picture we can see that this is the normal synapse with normal number of receptors. So now if there is decrease in the acetylcholine because of the SPCN damage, what happens is that there is an increase in the number of the receptors. Receptors get upregulated at the postsynaptic junction. So even dilute pilocarpine gave very strong results. So while doing the pilocarpine test itself, we had the idea because she was a student, she had her exams coming up. So we thought, why not rather than bifocals, why not rehabilitate her with 1% pilocarpine. So pilocarpine topical 1% was started, dilute concentration was used, and she was very happy with it. It restored her near vision to N6 bilaterally with the existent myopic glasses. She had reduced glare and headache partly due to partly constricted pupils, and the need for bifocals was avoided. After a month, she presented with the near vision of N6 without pilocarpine, which she had stopped on her own. Pupils were partly constricted around 4 mm. So recovery and accommodation was noted. However, pupils were still a bit partly constricted. They were not totally normal 2 to 2.5 mm. Pilocarpine was stopped for her. So coming to the discussion part, SPCN damage due to internal ophthalmoplegia after retinal laser is a rare complication. First, it was reported in 1979. There are few case reports, handful of case reports only are there. So, and also probably myopic eyes, what we saw in our case, they have a thinner choroid, so there is a higher risk of SPCN damage. So because there is no dissipation of the heat when laser is done. Thicker choroid in diabetics, older age, and hence low accommodative amplitude at the time of PRP, and coexistent maculopathy may be the reason for less reporting of this complication after PRP, which is a much more common procedure. Literature review was done. Whatever case reports and series we could see, accommodation recovery took 6 months or less in younger patients. In our patient, it was 1 month. However, in patients in their third decade or closer to onset of presbyopia, they showed poorer improvement. Anisocoria also decreased in all patients. However, residual anisocoria was present in even till 18 months in unilateral cases. where laser was done. Coming to the conclusion, how to treat such a case, probably you could use our method, which we use dilute pilocarpine drops, which is a novel method, and we are not concerned about safety and efficacy, which is a known fact. For hundreds of years it has been used. How to avoid such a complication? Laser power should be used to the minimum with gray white spots. Probably if too much of barrage area is there, we can split the sitting into two or more, and if we are
Time.
using slit lamp delivery, larger spots could be used. Thank you so much.
Thank, thank you for the nice presentation. One thing, just try to put scientific photographs in your picture, and especially if you have a dilated pupil, you could have clicked the photo with a phone only. है ना? If you don't have a recording system, that's fine, but you can click with your phone. Okay, so try to put photos of the patients, and even if you are you have given barrage laser, you have done barrage laser, you could have put the picture of the barrage laser, है ना? So try to put more scientific pictures. Okay.
Fine, ma'am. Thank you.
Yeah, and yes, and
And to add to a documentation which was must in this case. A documentation of pupil size
Yes.
was must in this case.
We could have done that. Probably I misplaced those pictures, so that's why I couldn't put. And
without
fundus
that-
picture we didn't have at that time, being in a government
Both.
setup, so that's why.
Both, you see, without that, this is the specific documentation about that. This has been changed. So we have to show the change.
Yes.
It's all theoretical what we are talking.
Yeah. You could have done like pre or pupil size, and with a picture of a pilocarpine and after picture. That would have given the impact of your presentation more. Okay, you can improvise this presentation now also. Okay.
With
Thank
the
you.
Photo of the PR